Hello, everybody, and welcome to our webinar this morning. We are excited to have you join us for Vaccines, Cancer, and COVID-19 with Dr. Sanjeet Dadwal, Chief of Infectious Diseases at City of Hope. I'm Jenna Fields. I'm the California Regional Director for Sharsheret, and I'm just so glad they are all joining us. I'm really looking forward to this presentation today in light of everything that's going on in our country. For those of you who are new to Sharsheret, we are a national nonprofit organization. We provide free support for women and families facing breast and ovarian cancer, as well as support for those with elevated genetic risk through free, confidential, and personalized support and resources. We also provide community health education programming throughout the country, including our webinar series. Since the start of COVID, we've been doing a webinar about every week. And we hope that you'll join us next week for our next webinar, which is on symptom management for anxiety and depression during and after cancer. Followed by the following week, we're doing something a little bit more light, which is a Shavuot Family Bake Fest. And then 2 weeks from now, we're doing a Zentangle therapy doodling program. Lots of great programs coming up. My colleague is putting information in the chat box. You can actually sign up right now. A few housekeeping items before we begin. Today's webinar is being recorded and it will be posted on our website along with the transcript. So don't worry if you miss anything from today, or if you want to send along to friends and family, you will be able to do so. And your names and faces will not be in the recording. We're now offering closed captioning for our webinars. Today's the first time we're doing it. So for anyone who would like closed captioning, simply click on the closed captioning button on the bottom of your toolbar. It is right next to reactions. Click on that and you'll be able to read along if you need to. And if you would like to remain private, you can turn off your video and rename yourself, or you can call into this webinar. And instructions for how to do that are in the chat box. Finally, Dr. Dadwal is going to start his presentation with a PowerPoint, and then we'll have time for a Q&A, which I'll be moderating. So please put your questions into the chat box at any time. We'll be collecting those and then getting to Q&A a little over halfway during the program. I want to thank our sponsors. Our wonderful sponsors are City of Hope, Merck, and CGen. Thanks to them, we're able to do this program. And just a little Sharsheret plug for you. If you haven't already ordered our Thriving Again kit, whether you were diagnosed 10 weeks ago, 10 months ago, or 10 years ago, we offer resources in this kit to help you navigate your entire survivorship journey. Each kit includes information on health and nutrition. It comes with an exercise stretch band, information on genetics, bone health. It's totally free and we customize it for you. So we are putting the link in the chat box to that as well. And please take advantage of that free resource. We'd love to send you one. Our medical disclaimer, Sharsheret is a national nonprofit organization and does not provide any medical advice or perform any medical procedures. The information provided by Sharsheret is not a substitute for medical advice or treatment for specific medical conditions. You should always use this information to diagnose. You should not use this information to diagnose or treat a health problem. Always seek the advice of your physician or qualified health professional with any questions you have regarding a medical condition. And now it's my pleasure to introduce Dr. Sanjeet Dadwal. He is the Chief of City of Hope's Division of Infectious Diseases. Dr. Dadwal has been on the front lines of the COVID-19 pandemic. He specializes in treating cancer patients who develop infections, a frequent complication of chemotherapy and transplants. His research focuses on understanding the mechanics of such infections and finding new ways to control them. After receiving his medical degree in India, Dr. Dadwal continued his training at SUNY Downstate Medical Center in Brooklyn, New York, and the Charles R. Drew Martin Luther King Hospital in Los Angeles. He is currently the principal investigator in a clinical trial researching an innovative new treatment for cancer patients with COVID-19 It is so our pleasure to have you here today, Dr. Dadwal, and please begin your presentation. It looks like you're muted, Dr. Dadwal.
I am, yes. Can you hear me now? Okay. Good morning. I just want to thank the organizers for inviting me to give a talk here. And thank you, Jenna, for the introduction. I'm going to share my screen here and we'll start the presentation. And, you already mentioned you've been having webinars through this past year and maybe even prior to that, and more so in the context of COVID. It has been an evolving field. When we first saw our first patients, at least at City of Hope, somewhere in late March, and then over the period of time in a variable fashion of frequency of admissions or outpatient diagnosis, how it impacted cancer care. And those of who don't know City of Hope, we're a standalone NCI designated comprehensive cancer center. And I've been here at City of Hope for 16 years and help our oncologists and transplant physicians managing complications related to infections. So COVID-19, I'm just going to give some perspectives in the context of cancer. Many of you have already heard this or seen this, and this is just a photo of City of Hope. This is Helford Hospital. This is our little garden here. And this is what we call coronavirus. It has a little corona around it, which is due to the spike protein. You can see this is the spike protein which the virus uses to get into the cells. So history of SARS is such, which is known as a virus which causes severe acute respiratory distress syndrome. The SARS-1 was initially diagnosed in 2002, 2003 with high mortality. There's no ongoing transmission. It was in Southeast Asia and was actually quickly taken care of. It had very high mortality rates. And then Middle Eastern respiratory disease, this is when MERS came out. And this is in 2012, fatality rates were up to 40%. And when you contrast that with SARS-CoV-2, which is COVID-19, so COVID-19 is a disease which is caused by SARS-CoV virus 2. So I'll just call it as COVID-19 because it's easy to say that. And the fatality rates with that overall is about 2%. And in some populations, if you look at those patients who have comorbidities like diabetes, elderly patients, that mortality rate goes high. And in cancer patients, it has been reported as high as 15 to 35%, depending upon different things like transplant, stem cell transplant, leukemia, or it's a solid organ cancer. And there's a variable presentation. Some patients have mild disease, others have moderate to severe disease. This is the SARS coronavirus 2, which is COVID-19 virus. Just a simple example. This is how the virus looks like. There's the spike protein, which attaches to a receptor in our respiratory epithelium and gets into the cell where it replicates using rDNA mechanism to replicate the virus. And then these are certain other proteins in there, but S and N proteins are the main one when it comes down to vaccination or how the vaccine construct is made. So this is a slide which I took out from a recent journal which was describing the impact of COVID-19 in ovarian cancer patients, but it applies to actually all cancer patients. At the beginning, when this started, and I'll show in the following slides, there were a lot of challenges, I would say, in terms of how much hospital beds we had and what the healthcare worker force was. I'm saying New York City, we all know how inundated it was. So there were closure of treatment facilities, there were cancellation of surgeries, there's mandatory testing of COVID-19, there concerns for delayed diagnosis or delayed screening. There's a question of quality of life and alternative managements, whether somebody is getting changed from an IV chemotherapy to an oral, maybe less effective, but again, in the context to mitigate risk of acquiring COVID-19 infection in patients of cancer. So epidemiologic consideration. Epidemiology means study of a disease or infection, how its patterns are, and how it relates in relationship to risk factors for developing severe disease or even contracting the illness. So as far as COVID-19 goes, the initial part, if you all remember, back in January, February, it was in Washington State. It was mainly in nursing homes around in Seattle area. Enclosed spaces are risk, meatpacking facilities, small concert halls. There was an outbreak in a group of people who were doing a symphony where there was, flute and singing. And then there are certain groups who are at high risk of worse outcomes. And one of the things which we've seen in this pandemic is that elderly patients, those who are above the age of 65, tend to have worse outcomes as compared to younger people. And then there are comorbidities, obesity, chronic lung disease, smoking, chronic kidney disease, those who have underlying heart disease, and I highlighted cancer and immunocompromise. That's what we are here to discuss today, and that's what I deal with on a daily basis in terms of managing infections. And also finding ways how to reduce the risk of transmission of infection within the healthcare setting. So this is a study which initially came out of UK, and this is the UK COVID cancer cohort. There were 1,044 patients who developed COVID-19. This is early in the pandemic, and this is their national, they have national services, the cohort of all cancer patients which are registered there, right there. And they were basically looking at if there was higher risk of getting COVID-19 in patients who had cancer during the pandemic versus their cohort without COVID-19. So you can see whether it is sort of impacted by type of cancer. So breast cancer is here, and then female genital organs, which includes ovary, endometrial cancer, or cervical cancer, is right down here. And you can see 13.7% with COVID, 16% overall cohort. And within the female genital organ cancers is 5.4%, those with COVID, and 6.4%. These were not considered to be statistically significant. So it doesn't look like that having a breast cancer or an ovarian cancer was putting patients at a higher risk to acquire COVID-19. Now, one thing I always like to mention is that COVID-19 acquisition has to do a lot with our surroundings, who is living with us, who is going out, what kind of jobs they do, and what can they bring home, and what is their likelihood of spreading it to others. This is again from the same study. This was published in Lancet Oncology. It basically shows the impact of age on what we call as case fatality rate, meaning the rate of somebody who develops COVID-19 and dies of it, hardly anything between 20 and 39. This is patients with cancer. Then you see it starts going up as we start aging by a group of 10 years here, and really takes off here at the age of 60 to 69, where case fatality is almost around 30%. And if somebody is above the age of 80, it almost gets up to 50%, which is really high. And even in those who don't have cancer, elderly patients are at the highest risk. And this is the cancer type. And we look at different things when we ascribe causality to increased risk for complications or deaths related to an infection like this and the cancer type. What you can see here in the breast cancer, it looks like this is what we call as odds ratio. This is the odds of developing an bad outcome if you got COVID-19. It seemed like having breast cancer was being protective. But when we factor in other factors that we call as multivariable analysis, when we start factoring other things, does somebody have diabetes, age, sex, and all that, then it seems like it doesn't make any difference. It does not increase the risk of death or even reduce the risk of death if you had breast cancer or a female genital organ. But if you look at other cancer types like leukemia, there's a significantly high risk of dying if somebody had leukemia and got COVID. So having breast cancer and ovarian cancer doesn't seem like it was increasing the risk of dying from ovarian cancer. That is a little reassuring there. Again, if we pool the cancer type, age, sex, and the case fatality rates from COVID-19, you can see at the bottom is breast cancer and then female genital organs. And this is by all patients. And this is women here. You can see down here. This green here means it's very low fatality rates, but it does increase. As you can see, go up to 40% if you're older. And this gray zone is that there were less than 4 patients, so they could not make any conclusion as to what the risk would be. And this is just one slide, which I would like to emphasize later on too, when I summarize the presentation, is that if you look at the 2 time periods here, January 6, 2019 to February 29, 2020, and then March 1 to April 18, 2020, the amount of screening seems like went down because we were seeing very less newly identified cancers. And we do know that screenings like mammography, pap smears, things like that were completely going to halt. The outpatient clinics were not accepting patients. They were going to basically essential care. So just highlighting a point that uh, having this pandemic put a real pressure on screening and prevention efforts we've made all these years. So that's just a general idea as to how breast cancer and female genital tract cancers may affect the case fatality rates or mortality. And now going to a common question which I get is, what if I get COVID-19? What I do? So if you go by the NIH definition, there's a mild disease. These are patients who have cough, cold, fever, may have lost their taste or smell, but they don't have shortness of breath. They don't have pneumonia. Their oxygen is more than 94%. Typically, we recommend those patients staying home because there's no FDA approved or EUA treatment for them, with the exception of monoclonal antibodies. So here's where I say having a very close communication channel with their oncologist is the key. At CityFO, what we were doing is my division, we were actually screening any positive test which was coming in our healthcare system, meaning on our Duarte campus, and we were proactively reaching out to patients saying that you meet the criteria, would you like to get this antibody? And this is under emergency use authorization, which had shown that in patients who are at higher risk, if you would give this antibody within 3 to 4 days, the chances of developing moderate or severe disease or getting hospitalized goes down significantly. And moderate or severe disease is that situation where you're requiring oxygen or have pneumonia and require hospital admission. What are the available therapies? In the US, so far only remdesivir. It is only approved for patients who have moderate to severe disease, hospitalized patients. We have emergency use authorization. There are 2 monoclonal antibodies which are available, and then high titer convalescent COVID-19 plasma. So this is a plasma taken from those people who have recovered from COVID-19 and have high titer antibodies, meaning high level of antibodies, and that may protect. There are immune modulators we use. This is in patients who get admitted, and this is basically to blunt the immune response, which the body does in response to COVID-19, what it triggers. And then anticoagulation because there's increased risk of clotting. And finally, prevention with vaccines, which became a reality somewhere late December for healthcare workers, frontline people, and now to our patients. And this I will bypass because we just spoke about that. The other thing which a lot of our patients were concerned about, mutants or variants which are coming out, and there are different kind of variants. There's a UK variant, there's a Brazilian, there's a South African. Now we know there are variants from India, and also within the country, like in California, we have variants too. But the major variant now in the US is UK variant. And this picture is about 2 weeks old, and I did not update it yet. But this, you can see it's distributing in the United States, but it is much more now at this time. But South African and Brazilian is still pretty uncommon. So what happens is variants are produced by mutations in the spike protein, that little spiky protein which attaches to the cells and get into the cells. What that does is it changes its configuration so that the antibodies which people may have had with the prior infection no longer neutralize this virus. And the concern is, how does it impact transmissibility? We know they're more transmissible. Do they cause more severe disease? Well, there are reports in the UK, yes, it does. But I think the risk of more severe disease is also because if you have a pool of patients who are at high risk, they can get severe illness. Response to treatment, there's no evidence that current regimens like remdesivir are less effective. We think they are equally effective. There could be a concern in regards to whether plasma will work or the monoclonal antibodies will work. But in terms of vaccinations, we do know that the vaccines offer some protection even against variants. So SARS-CoV-2 vaccines. So vaccines, as you know, are used to induce an immune response in a person who previously has been infected or not infected to develop antibodies. So the next time body sees a virus, it goes and fights it. So there are different kind of vaccine vehicles. It's like I say, a payload system, how you have a rocket which takes something into the space. Same way, you have a base which carry certain molecules to which the body is going to respond and produce antibodies against the virus. So these are vector vaccines, AstraZeneca, J&J. They use a adenovirus. It's a kind of virus which causes respiratory illness, but these are incompetent. They do not replicate in the human body, but they're used to take those little proteins into the body, and the body then reacts to that and produces antibodies. The vaccine, which is made by Moderna and Pfizer, is a newer vaccine which uses a different mechanism. Here, these are mRNA. mRNA is actually produced outside. It goes in and it is released into the cell, where then it replicates, it generates the spike protein, which is expressed on the cell. And the body then identifies that and induces an immune response. And then we have protein subunit vaccines. This is Novavax. These are spike proteins covered in nanoparticles. The last one is not yet available in the US. We have Moderna, Pfizer, and Janssen. J&J is again, the hold has been lifted by FDA and CDC that is safe to use. Again, this is a little more detailed look. AstraZeneca efficacy was 82% after the second dose with the boost. J&J, it's 67%, but again, it really protects against severe disease. That's what we are trying to prevent. As number one, we don't want to get the disease. Number two, if somebody does get infected, they don't develop a severe disease or get hospitalized. And as you can see, Moderna and Pfizer are about 95% and Novavax 96%. This is the City of Hope vaccine. It's still in phase 1 trials in healthy adults. Our vaccine is unique that we are not just focusing on the spike protein. We're also focusing on this protein, which is inside, known as a nucleocapsid. Although the spike protein is the one where you see the mutants and variants more often, nucleocapsid seems to stay stable. So having a vaccine which induces an immune response against both, and also the nucleocapsid tends to induce immunity against what we call cellular immunity. These are our cells, T cells, which are like memory cells. They stay in your body and you get exposed to virus again some point and later in time, they become active and start basically pulling all aspects of the immune response into play. And this vaccine has been shown to induce a very good antibody response as well as T cell immunity response to SARS-CoV-2 virus in animal models. And we are also seeing that in our phase 1 clinical trial, healthy adults, that it induces a good antibody response and a T cell immunity response. And that is important, especially in patients who have underlying cancer, because we rely not just on antibody, you also want to have a good cellular immunity too. And the City of Hope vaccine uses a different vehicle. It's a Vaccinia virus, which is basically a attenuated strain of Vaccinia. It's known as MVA, modified Vaccinia ankara. It does not multiply in the human host, and it has a superior T and B cell response. It does produce long immunity, and there's actually experience with this vehicle as well. Say 150,000 people have been immunized successfully in the past, starting in 1970s. There is an FDA-approved drug for smallpox and cowpox using this base, meaning vehicle. And we have also used this vaccine in our transplant patients for CMV infection. But the COVID vaccine using the same inactivated virus is only for healthy adults at this time. Now, there are vaccine-related topics with which there are increasing concerns. What is the efficacy of vaccine in a cancer patient? Well, we don't know, because all of these vaccine trials, they did not include patients who are actively undergoing chemotherapy. And knowing from our experience in the past that patients who are on active chemotherapy, depending upon the type of chemotherapy, vaccine responses are not that great, including vaccines like flu. So typically we wait till the chemotherapy is done, your immune system is a little recovered, and then go to get vaccination. Typically, that's a decision which is made by a physician with the patient based upon the patient's overall clinical situation. We do know that COVID vaccine has not been very successful for patients who have cancer of the blood, meaning leukemia, lymphoma. It has poor vaccine response to the tune of only about 20 to 30%. There was also a study that came out of Johns Hopkins that patients who had organ transplant like liver, kidney, their response rate was pretty poor too. And patients who undergo chemotherapy, it is my recommendation, always talk to your oncologist about the timing. Chemotherapy regimens have changed so much, including for breast cancer, for ovarian cancer. Obviously, I'm not competent to discuss about which chemotherapy to give, but we know there are chemotherapies which are very immunosuppressive. Then you may have hormonal therapy, which probably does nothing to the immune system. So it should not impact the vaccine response. And then we have immune checkpoint inhibitors, where there's a concern that it may actually induce a more vigorous vaccine response, which, may translate into increased side effects. So all of those things need to be taken into context. NCCN provides guidelines on SARS-CoV-2 vaccination in cancer patients, and vaccines are recommended even if there's prior history of COVID-19. As patients with weakened immune system may not develop antibodies with a natural infection. So let's say somebody had infection and they tested the antibodies, they were negative, or they had antibodies. Those antibodies typically wane over a period of 3 to 6 months. So they may lose the immunity. These coronaviruses have been with us for thousands and thousands of years. There are other coronaviruses, we call them endemic. They cause common cold. And a person can get the same virus multiple times in a year. It doesn't induce a lasting immunity, but there was no vaccine in the past, and there was no interest in vaccine because it caused mild illness. But with this pandemic virus, SARS-CoV-2, with its mortality and its impact, that's how the vaccines came about. And it seems like in healthy people or those who have immune system which can react, there's a good vaccine response. We do not know, though, how long that vaccine response is going to last, because the vaccinations really started in the context of clinical trials back in April or May, and in real world in patients somewhere in January or February. So the bottom line is prevention is the key. Until effective therapies are available, we still need better treatments, antivirals, which can be taken by mouth. They're easy to give rather than IV and getting hospitalized. Vaccination is the key at this point, and other effective measures, masking, physical distancing, and avoid crowding. What applies to general population really doesn't apply to cancer population. And I wish all the authorities made that distinction at the very outset. So if you look at all these societies, like I sit on American Society of Transplantation and Cellular Therapy and ASH, and also an NCCN, we make a comment that please do not stop doing what you're doing right now, such as physical distancing, masking, because you don't know who you're coming in with if they're not vaccinated. Now, some patients or people, or even healthy people who are vaccinated, they can still get COVID. They may not get sick at all, but they can shed the virus and pass it on. So it's very important to be careful. Classic example is India right now. They were very careful all through the pandemic till January, and suddenly they let go of all their guard, and only 2% of that country is vaccinated. So at least we are better off with vaccination. At least in the state of California, we're more than 50% vaccinated, and it's going higher and higher. So getting much more population vaccinated is going to help us in the end. But what's happening in India is a clear example. There's no immunity, and people left their, let their guard down, and it's going crazy out there. Acceptance is very important, that the way of life has changed, and maybe we have to change for the long haul to combat this pandemic. It's not going to be over this year. I'm saying there will be little spikes here and there, but hopefully it won't be what it was like last year around Christmas or January. So having consistent behavior change in the long run is going to be critical. And this is us as healthcare providers, patients, caregivers. So it's a whole continuum where this needs to be applied. If it falls in one group, then it's going to impact everybody else. And then example setting. So we always need to have role models within the communities, within the hospitals, societies who are going to be passing on this message that it's still very important. Because the thing is, if you get COVID and you're a cancer patient, it can delay your cancer treatment, which means the disease can progress. There could be more complications if the immunity is weakened. And the things we have right now are really not, perfect. So we still see bad outcomes with COVID-19 in somebody who's severely immunocompromised. So I say peace at the bottom because that's prevention, that's effective measures of masking, physical distancing, accepting that we have to change our way of living, consistency with those things, and example setting. So that's my way of saying peace. And I'll take questions. Thank you.
Thank you so much, Dr. Dadwal. This was, I took notes the whole time. This was so informative. Thank you. And I'm going to keep peace in mind. It's going to have a new meaning for me going forward. So lots of great questions that have come up. I'm going to start with your second to last slide, just about how you mentioned there are not studies yet that have been done specifically on cancer patients and a vaccine efficacy. Can you address, or are there any studies that are starting, maybe at City of Hope or somewhere else, that are starting to look at that?
So NIH just declared that they're doing a study where they are asking patients who have received vaccination if they want to get tested for immunity. So that's one place. City of Hope, they are doing in genitourinary cancers, especially kidney cancer, prostate cancer. There's a clinical trial being run by Dr. Samantha Paul, where we are looking at antibody response as well as T-cell responses. There's also society-based, different societies exist, lung cancer and others. They could be doing those too. In terms of vaccine trial, I don't know, you just wanted me to address about immunity for now, right?
Yeah, but you can expand.
So we are also thinking of doing it in the transplant population. But again, at this point, if you look, CDC as well as the people who make these vaccines, checking for antibody response is not recommended. Because we do not know at this point, having an antibody, how high that antibody level is, which is protective, because you may not get the titer with every test. How long does it last? So those are the key factors. And obviously that information is really missing in cancer patients completely. We don't have that.
And you had talked about people with blood cancers. There is measurable less efficacy in terms of vaccines. Is that for people who are currently in treatment or people who are also completed with treatment?
No, mostly these are patients who have conditions like lymphoma or CLL who are actively getting treatment or recently out of treatment. We've had patients who've had CAR-T for, let's say, lymphoma, and they got the vaccine a year later, they still could not produce any antibodies. So it all depends. That's why having a dialogue with the physician is so important, that, hey, I got this chemotherapy or this treatment. How long does my immune system, stay low before it becomes competent again? What's the best timing for vaccination? Things of that sort.
And kind of following up on that, we did receive a lot of questions about chemotherapy specifically and timing a vaccine. You mentioned in your talk, that's a really personalized question that people should be asking their doctors. From your observations, you have a sense of how long people can wait? Or is there any sort of window that you can share with us, or is it just too specific?
Yeah, so again, I'll break it down into two parts. Number one, somebody is on a routine treatment, meaning they're not on clinical trials. A clinical trial has a different context as to whether they allow the vaccine, they don't allow the vaccine because it's an EUA vaccine. But for the most part, I think they have made that exception. They now allow EUA vaccines too. The point is, I'm saying, when do you give it? And we had dialogues with our oncologists. And because there's so many different regimens now, let's say, for example, you have breast cancer. You can have just hormonal therapy, or it could be chemotherapy with targeted therapy, trastuzumab, pertuzumab, plus carboplatin, or things of that sort. So what we have to look at is, what is the timing? So if there is time, you can wait to start chemotherapy. We typically say give vaccine at least 2 weeks before starting chemo. That's the first. But then the second shot has to be given 28 days later. Now, what 28 days later, if you have white cell count of 0.5, then you may not respond to the vaccine. So I really think it has to be based upon what is the frequency of cycle of different chemotherapy. Is it hormonal therapy? Is it targeted therapy? If it is targeted, we don't care. Go ahead and vaccinate, because it doesn't really affect your white cell counts or your lymphocyte count. If somebody is on steroids, let's say they got immune checkpoint inhibitor and they develop side effects and now they're on steroids and the vaccine became available, we do know that high dose steroids do not allow any vaccine response. It's very poor. So we wouldn't recommend vaccinating then. So those are the caveats.
Got it. And for our population that is maybe about to go into surgery or radiation, are there those same concerns, or is it really chemotherapy where the concerns lay?
No, it could be concerned with radiation treatment too, because that also impacts the immune response. Surgery, I would say it's a very short period where you would say don't give it within a week or so. But I don't think going in for surgery, let's say it's mastectomy and it's localized radiation, I would still go ahead and vaccinate that person.
Okay. Thank you for addressing that and expanding a little bit more. So I did get quite a few questions. I'm going to get through as many as I can. Someone wrote, they thought that, and I know this is something that we are still trying to understand from the news, but if you get the vaccine, you can't spread it anymore. You can't spread the virus. Can you elaborate on whether that's true or not?
Well, I'm saying from what I know, the Janssen vaccine was the one which actually showed that it actually cuts the transmission also. But on the other side, if you look at Pfizer and Moderna, it was 95% perfect, in terms of efficacy, but 5% it wasn't. So you have those people who may not respond. I would say they responded to vaccine, didn't get sick, but they got the virus. They had a mild disease. So if they have the virus and they're shedding the virus, then there's always a concern they can spread the virus.
Right.
Especially more likely to spread it because they are more likely to be asymptomatic and they're less likely to, stay away from others.
Okay, that makes sense. And just to follow up on radiation, someone asked about past radiation. Does that affect the immune response to COVID?
It depends. I'm saying it depends upon the dose. So, we say typically probably wait 2 to 4 weeks post radiation, at least 4 weeks, if somebody could.
Okay, but a year ago, that's not a concern.
It should not be a problem.
Okay, and I know it sounds like you're getting a little bit muffled. I'm just going to ask you to.
Oh, sorry again.
No, it's okay. I know when you're so passionate about a topic, it's easy to.
I just put my mic down. That's all.
And we did get a few questions regarding pregnancy, and we do actually have a large population who's also has increased hereditary risk, specifically BRCA as well as other mutations like CHEK2. Can you speak to some of the concerns that are going around about pregnant women getting the vaccine and any concerns for people who maybe have hereditary risk for cancer?
Yeah, I'm saying there's not much out there. So CDC does not advise against vaccination, even of pregnant women. So that's probably all I would say. I will put a disclaimer that being at a cancer hospital, I've not seen a pregnant patient in 16 years. So I will be overstepping my bounds there.
Is there a resource you can recommend for anyone who does want that information?
I can find out and email you.
That would be great. Thank you, Dr. Dadwal. And in terms of, so someone asked specifically about the efficacy of shingles vaccine and if it impacts the COVID-19 vaccine, but maybe even more generally, if you've had a vaccine for something else, can that affect the COVID vaccine's effectiveness?
I don't think so. There shouldn't be any sort of impact in reducing the vaccine efficacy if you got any vaccine in the past. The only thing we say is try to space the vaccine by at least 2 weeks so it becomes a little murky which vaccine gave you side effects if you took them together. So space it out by at least 2 weeks. That's the recommendation. If you get a flu shot, then make sure you take either 2 weeks prior to the COVID vaccine or 2 weeks after the second dose.
Great. And I'm going through all these questions while listening to you, so I apologize for the delay. Can you talk a little bit in terms of, the City of Hope is doing this clinical trial. It was really interesting to hear about how you're addressing the inside of the virus instead of the spike proteins. That was a really great visual. Are there other studies like that happening around the world, or is this really specific to City of Hope? And what do you think the chances are of us seeing a vaccine like that maybe this year going to market?
We're making full efforts in getting the phase 1 done. That's for 126 patients. So the enrollment is ongoing. And again, as I said, the vaccine uses 2 targets instead of 1. And it's also effective against variants. I do know other people have researched on that, but I couldn't find, at least in the US, I don't see any other trial which uses a vaccine model where you're using 2 targets. So that's one. We are looking at possibility of expanding this as a phase 2 trial in certain cancer population, but we're still in preparation stage. I can't say more than that. So that's on the vaccine. And beyond the vaccine, so we have a phase 1 trial of using a drug which is used for rheumatoid arthritis for treating patients who have severe disease, because it actually cuts the viral replication and also reduces the inflammatory response.
And do you think that trial will be completed soon, or?
No, I'm saying our numbers are down in LA so much. So
yeah, it's hard to
obviously
find participants. It's a good problem to have in some ways, but
that is true. I would rather have no patients and wish them the best and good health.
Are there other studies like that, though, happening in other places around the country, treatment specifically for people who have COVID who are also getting cancer treatment right now?
Yeah, so this study we have, which is for leflunomide, is specific for cancer, and it is actually funded by NCI and philanthropy at City of Hope. Similar studies just targeting cancer? No, it's all comers. So there are other studies, there are small molecule studies, different pharma studies, which are coming into picture. There's a new antiviral by Merck, which is coming out. It's given as a pill, shows promise, but it's still in phase 2 trials. There's nothing which is close to, coming as an access to patients yet.
Got it. Okay. Can you talk a little bit about the side effects of the vaccine? Or are there any differences in people who are in treatment or survivorship expect in terms of side effects? And if you have more side effects, does that increase your level of protection?
So the side effects in relationship to vaccine, again, as I said, this is basically available from clinical trials. That's number one with Pfizer, Moderna, and J&J. And then we are putting it out into general public, and you're hearing things through the Vaccine Adverse Event Registry VAERS database, and people reporting to that. Those things are still being looked at, what is going on. And you see in news what really stands out, like clotting and other things, but that's extremely rare. So the most common side effects are injection site discomfort. Some patients may develop fever. Some may get joint pains. One of the things we've been seeing is development of swollen lymph node in the armpit or in the neck, and how that poses issues for patients who may have cancer. Is it cancer related? Is it treatment related? From the vaccine. So those are the key things. For the most part, we don't believe that there should be any difference in the side effect profile between a cancer patient and general population.
Okay.
Our transplant population looked at their patients. They're writing a study up, a paper now, and they did not see, they saw that the vaccine was pretty safe in them too. We don't know whether it was effective, but it was safe.
And can you address booster shots for, obviously you address concerns around variants. Do we expect to all be getting booster shots in a year from now or sooner?
Don't know, to be honest with you. So there's no guidance in that at this point in time. We don't know how long the vaccine effect lasts. So if it is like any, flu vaccine where the impact goes down and you have new variants coming all the time, flu, at least it's an annual thing. This virus it's not limited by season. It's all over the year. It's been in summer, winter, spring. So it's not seasonal virus. So you really cannot predict when that variation is going to come. With flu, you can do that. So whether we're going to do a booster or not, I don't know. My gut feeling, probably yes. But at this point, there's no recommendation.
Okay. Someone asked about your rheumatoid treatment. What exactly are you researching?
So it's a drug known as leflunomide, which is given by mouth for patients who have rheumatoid arthritis. Rheumatoid arthritis patients take it for months and years. For here, it's available on clinicaltrials.gov. We give the first loading dose and 1 pill a day for 14 days. And we're basically measuring the response to treatment by seeing how much virus is being shed in the nose. So we take samples every other day. We take blood samples for assessment of antiviral levels in the blood. And we also do liver tests and other tests to make sure it is safe. So far, we've not seen any safety concern.
That's great. So many questions I want to make sure that we get to. So people who maybe are, still feeling concerns around the vaccine, because, as you're sharing, we're studying, so much in real time. What would you say to them?
So I would say vaccine is probably the best option available, along with, what we've been doing: masking, hand washing, hand hygiene, physical distancing. But vaccine decision-making really should happen with your physician. And that is very important to know, because your physician can guide you that you can take vaccine right now, but it's not going to do anything for you. So like in my hospital, we say that if you're on steroids, more than 0.5 milligram per kilogram of your body, so if somebody is 70 kilos and they're getting 40 milligram prednisone, please don't get vaccinated, because it's not going to do any good to you. It may give a false sense of security that, oh, I'm vaccinated, I'm fine. So that should not be the case. Same way, if you're on chemotherapy, certain chemotherapies, please talk to your doctor. If you're in a survivorship phase, you're a year out from your cancer treatment, you're not on anything, then it's fine. Go ahead and get vaccinated.
And for people who haven't been able to take the vaccine yet for any of the reasons you've described, do you have recommendations for them keeping their immune system strong right now?
There's really no other way. It's just be meticulous in staying away from somebody who could have the virus. So if I have my household, the only person who's not vaccinated is a 10-year-old. And my 10-year-old is actually so meticulous because he has a 75-year-old grandma at home. She's vaccinated, but when he goes to school, he's double masking. He's probably the role model for the whole class and for our house too. Especially for my 18-year-old son, he tells him, hey, you can't go there. You can't go there. You'll bring it to grandma. You don't know how the vaccine works. So I think if you're in that group of, which cannot respond to vaccine at this point and delaying vaccine, then the key part is make sure everybody around you gets vaccinated. That's number one. So we've been harping for a long time to authorities that for cancer patients, please, please, please have their relatives or caregivers fully vaccinated, so you have a wall of defense around them. So that way they will not bring it at home. So all the cancer patients we had at City of Hope who had severe disease, it often turned out to be a child coming back from work or traveled somewhere, came and gave it to father or grandfather, and then they ended up in the ICU. So that's a key part. Surround yourself. Now, the vaccine is freely available in great parts of the country. So go ahead and get vaccinated and keep your loved ones safe who are getting chemo or who don't have, adequate immune system yet in place.
Can you share in terms of children getting vaccinated? My pediatrician says it's going to be maybe December or January. I don't know, maybe other pediatricians are saying something else. But do you have any reservations in terms of vaccinating children or anything you would recommend to parents around that?
Personally, I don't have a concern. I even asked my 10-year-old if he wants to participate in a clinical trial. He told me no. He said no.
Sorry, Dad.
Give me good reasons. But I think it's already approved for above the age of 16 for one of the vaccines, I think. And Pfizer is applying for EUA to give it for kids above the age of 12. And I know there are clinical trials between the ages of 6 and 18 too, ongoing. So that's all I know for now.
Is there any advice you would give to, I think is a very important conversation that we're having, and also I think sobering, especially in light of the mask announcement yesterday. It can be a little deceptive, especially for people who are maybe still facing treatment or in survivorship. The community that is on this call today. Can you share maybe some tips around having this conversation with family and friends who maybe feel like things are open, we don't need the same concerns anymore?
Yeah, so we actually put out we have FAQs for our patients, which are listed on City of Hope's site. And we clearly made a point when CDC came out a little while ago that if you're vaccinated, you can take off your mask and you can get together in your house, 5 or 10 people. We made that recommendation very strongly to our patients that even if you're vaccinated, but you're on chemotherapy or you are on immunosuppression after transplant, we do not know whether you are protected or not. And there are already cases actually of multiple myeloma patients who got vaccinated and got severely sick with COVID because they never mounted an immune response. So that may not be true for breast cancer patients or ovarian cancer patients, especially those who are in survivorship or even those who are on targeted therapy. That risk is not the same. It's a completely different population. The point I'm trying to make is that when you do not know, or you know and you vaccinate somebody who doesn't have adequate immunity, because CDC said even if you have 10% chance, 20% chance of inducing an immunity, go ahead and get vaccinated. But in essence, we don't know. So in that context, I think it becomes very important for the person who's undergoing treatment as an advocate for themselves, talk to their kids in a very nice open fashion and say, you know, we miss you, we want to be around you, we want to hug you, but here's the story. This is what's happening to me. And those parents who are younger and have cancer and maybe they have kids, it's even tougher because the kids have to go to school, they're coming back, and they could bring it, but we can emphasize to those kids, hey, don't take your mask off at school, wash your hands, but kids are kids. So that we cannot run away from, but whatever we can do, I think we should make full effort in doing so.
Right, right. Oh, I think it would be great if we could have that resource that we could send out following the webinar that City of Hope created.
I'll ask our legal folks if they can.
Okay, if it's possible, if it's not possible. And I think I should plug our social work team for anyone who's having challenges navigating difficult conversations with your family. We are also available to talk with you about that. Is there a way to test if you have developed any sort of immunity? And is there any value in antibody testing at this time?
So at this point, as it stands, CDC and the people who make vaccines and even the disclaimers of the companies which do the testing is, we do not know how to interpret the test. You may have the antibody and you still may not be immune. I'm saying a healthy person, fine, you have the antibody, you're potentially immune based upon the vaccine trials because it's 95% efficacious. But the recommendation is not to test. That's what it is. But if you want to get tested, it's probably best to find a clinical trial because at least they will be sending out a correct test. We've already seen some of our physicians order an antibody test because the patient wants to be tested and they put in the wrong test. So they ordered a test which measures N protein antibody. You don't need that because that only happens with natural infection because none of the vaccines have the nucleocapsid protein yet. So you need a spike protein specific IgG antibody at specific labs. So that's very important. So I would encourage if you can find any local place they're running a research protocol where they're doing antibody testing, that would be the best way to do it.
Is there a place where our participants can go to find those clinical trials? Is there a good central hub?
One is clinicaltrials.gov. The other is always look at NIH and the respective societies like, Leukemia and Lymphoma Society, they're sponsoring a study, so they have it on there. So if there's a breast cancer consortium or study, go to that site and see if they have there.
Great, great. Well, Dr. Dadwal, we could keep this conversation going. We so appreciate your time and expertise. I think we got to most of our questions, but I know not all. So Dr. Dadwal very kindly offered to answer a few more, which we can send out afterward. I want to thank you and everyone for joining this call today. Please, if you're interested in our 3 upcoming webinars, we hope that you sign up. My colleagues will put those links back in the chat for you right now. You can also sign up for our free survivorship kit, which we'll put back in the chat as well. Just click to that link. And thank you to our sponsors, City of Hope, Merck, and CGen for your support. And we look forward to seeing you all next week. Thank you again.
Thank you very much.